Well, thank you very much. Firstly, I would like to say I'm not an expert on NTDs, but I have always worked in the field of nutrition and particularly in programming, and it's some examples with respect to programming that I've been asked to speak to today. That's just an overview. But generally speaking, I think the relationship between NTDs and nutrition is quite strong, with malnutrition being both an outcome as well as a risk factor. In terms of sort of the influence of NTDs on nutritional status, it's both in terms of the infection itself, perhaps increasing the metabolic rate, increasing nutrition requirements, increasing the nutrient losses, as well as even having an influence on appetite. And apologies. and likewise, also nutrition can influence the severity of disease, vulnerability, chances of reinfection, etc. So it's part of that sort of vicious cycle between infection and nutrition that some of the NTDs are part of. Why then integrated programming? Well, besides sort of the fact that the effect of a mass drug treatment can have on the nutritional status and vice versa, even some of the other factors that influence both risks of NTDs as well as risk of nutritional problems such as water and sanitation all really amplify the impact that one condition have on the other. Well, I guess I should also mention here that that behavior change here is not just, as I will come to, as indicated on this graph or this figure in terms of sort of informing people, but also in terms of even creating a demand for those services that are then those interventions that are being delivered. So there's lots of programs ongoing with respect to integrating, especially deworming with, for instance, vitamin A supplementation or iron supplementation. I think UNICEF is probably the biggest with respect to doing integrated programming. And integrated programming can be done both in terms of sort of the, can we call it geographic convergence, in the sense that you use a similar criteria for deciding where you're implementing. So for instance, that you choose to implement some of your deworming programs in areas where there is poor nutritional outcomes. Or it can also be in terms of co-delivery of programs or if interventions in the program, like there is examples here. And earlier there was a mention of the Canadian government and their contribution, and they have been, for instance, a great contributor to organize small organizations like HKI and MI with respect to, again, vitamin A and deworming programs being delivered in an integrated manner. The concern that I would like to raise here is more with respect to uptake of services. One thing is that we can deliver them jointly, but the challenge will still be to get people to utilize those services, because otherwise they're never going to have any effect. And that requires them to change their behaviors, either whether or not it's to do with the uptake of a single dose regimen or adherence to a longer drug regimen, or with respect to more behaviors that needs to be sustained for longer over time, whether it is preventative behaviors such as wearing shoes instead of walking barefoot, or whether it is with respect to hygiene, personal hygiene, sanitation, or with respect to nutrition and eating behaviors. And I would also like to raise the question whether or not the channels that are currently being being utilized primarily for these integrated programs, whether or not they are the most effective. I don't know if you noticed, I had highlighted that almost all of the integrated programs that are being done are usually done either through schools or through health services. We had the question from the floor earlier in terms of utilization of primary health care services. And the challenge here is, of course, for instance, with children under 5, we do have integrated services available to them, child health days, etc., where deworming vitamin A is being offered at the same time. With respect to routine services, they're there. But the uptake of such services dramatically decrease around 9 months of age, when vaccinations are less frequent, and subsequently that's maybe not the best way by which to deliver such integrated programs. Similarly, one thing is schools, but what about all those children that drop relatively early out of school? What about our opportunities to reach adolescent girls before they get pregnant? Yes, we have programs, integrated programs delivering deworming medicines together with iron folate supplements during antenatal services, but these women represent usually late, especially in their earlier pregnancies. And also, we know that the opportunity for influencing their health and nutritional status, the window is relatively short during pregnancy, so we really need to reach them before they get pregnant. And how do we best go about that? Because they do not, go to health facilities and access such services even when they are available on a regular basis. So I would like to just give a few examples of some innovations in programming. There's lots of other things being happening around, and I'm excited also to hear some examples later on in the session. But I'll just share a little bit in terms of innovations in programming, one with respect to approaches to behavior change, and secondly with respect to the channels for delivery of services. So the first point I wanted to make here was with respect to our approach to what influences people's behavior. We're always talking about information, education, communication, but who says that it is knowledge that an individual needs in order to make that decision? We probably all know it from ourselves in terms of whether or not we do get our 30 minutes of moderate exercise a day, or whether or not people choose to smoke or not, and what they have for dinner, etc. And the same goes, of course, for everybody else. And whether or not we adhere to a drug regimen or other behaviors that we in the health sector are very good at telling people that they need, but that individuals might not see a need for themselves, or really fully be incentivized because to do because maybe there's other barriers or other influencing factors that are much stronger influences in their lives. Here's an example of sort of an outline of human motives by Lyle Curtis and colleagues at the London School of Hygiene and Tropical Medicine. This is part of the hygiene center there, and their model really focuses on the fact that it's not a rational brain that makes decisions, but it's our drives, it's our emotions, and it's our interests that influences how we make decisions instead. And we have been working together with them to be utilizing their EVO-ECO model for nutrition programming. There has been quite a lot of success with it in terms of water and sanitation. They're working closely, for instance, with Unilever. And we are also trying to take that same approach to what influences our behaviors into nutrition programming. And just as an example, I'm not going to go into detail. If you do have an opportunity to one day hear Val speak, then I will definitely recommend it. But just to highlight that it's not just a question of providing an individual with knowledge and telling them that they must, for instance, take 90 tablets of iron folate supplement, or go to the clinic and take their deworming medication, but that they're influenced by many different things in their environment, whether it's their social environment or their sort of physical, biological environment, as well as the various parts of the way the human brain functions. We have utilized, as I mentioned, their approaches to behavior change to really think beyond interpersonal counseling. I think within the field of nutrition and health, we seem to think that by providing counseling by a primary health provider, that we are able to influence people's behaviors. And anyone who has been working in a health facility in a developing country will see very quickly that the likelihood of that having an influence is going to be very limited. Another example is, for instance, the growth monitoring sessions. These are just kids being put in the bags and being weighted quickly, you know. There is maybe 50, 100, 150 kids that needs to be all weighted in the morning, and then there's maybe one nutrition education session afterwards if the mothers hang around. But the mothers, of course, have all these other things that they need to do at home, taking care of their family, fetching water, etc. So one of the things that we have been working on is, instead of utilizing sort of the traditional interpersonal counseling, to instead do things that are much more interactive and much more fun and games, and not about providing people with the information of what is the right thing to do. An example is, for instance, exclusive breastfeeding. Find me a mother in any country who doesn't know that exclusive breastfeeding is best. The difference is whether or not she practices it. The approach that we are taking here is, again, not about telling a mother that she should be practicing a certain behavior, that she should be eating in a certain way, feeding her child in a certain way, etc., but instead trying to get to that aha moment and trying to tap into the other parts of what motivates a certain behavior. Another thing that we in the health and nutrition sector perhaps are not so good at, which the private sector marketing is much better at, is for instance, to use multiple channels for the same message and also having fewer messages. So that's also an area that we have been working in. And also to make those messages much more aspirational. Again, within the sort of health and nutrition sector, we also always say, you should take, and not really, you know, making it a behavior or something that an individual would want to do because they aspire to do that. So yeah, we try to apply what in marketing they probably would call 360-degree marketing. Again, to reinforce the same messages through a whole variety of channels at various pinpoints in the community, various pinpoints in you know, from their TV, their radio, their mobile phone, etc. All at the same time, all with the same messages, all under the same brand. So that was a bit in terms of behavior change. I think another area that we could really do a lot more in is with respect to the kind of channels that we're utilizing for service delivery. This is still something that we are wanting to, well, with everything, it's an area within GAIN that we are you know, just starting to slowly explore, especially when we're talking about, for instance, workplaces. We have, in the past, been doing a lot in terms of food products, etc., but we are talking about behavior change interventions and other interventions in the space of nutrition and health. Then this is a newer area for us to really engage in terms of different channels for service delivery. But one example that I just wanted to highlight is with respect to utilizing where people are on a day-to-day basis. Of course, there's lots of issues with, well, not issues, but there's lots of self-employment, etc., but there's also means about how to go about that through community-based programs, etc. But we cannot forget that a lot of people are actually employed, and that it provides us with ample opportunity to reach them through their places of work. So for instance, we are working in garment factories in Bangladesh to provide women in the factory with both deworming medicine or tablets, nutrition education, iron folate supplements, and more. One of the things that we are hoping to do is really trying to look also at the impact it has on productivity, so that in this space, as was also mentioned earlier, or era of limited financial or resources for health, that by providing evidence of improved productivity, we can make a case for it being worth the that there is a return on investment for our employer, so that it's worth it for him to deliver these interventions out of his own pockets for his own staff. Another area that we're working in is also with tea plantations. Similar, that can be both in terms of outgrower schemes, and there's lots of other, as well as plantation and individuals, just working day workers, day laborers. But there's, of course, lots of other opportunities. Thinking of Kenya, flower plantations, etc., etc. So there's lots of opportunities. It's just something we're, I think, in this field are starting to scratch into. Then there is also other channels for service delivery that doesn't necessarily need to be directly related to the actual physical delivery of services, but also, again, in terms of increasing the demand and the utilization or uptake of services that are being delivered through other channels. And here I think that mobile is a space, and social media is a space that needs to be much more explored. It has been already, and something we can all do much more in. And also thinking of it, maybe not just to layer nutrition messages into what we call M-health services, but also think of what other services, mobile services that are available. So one example, for instance, what we have done is working with existing services in a handful of countries to layer nutrition messages also into existing health services, but also expanding the time frame of the health services. An example is a very popular service, part of a public-private partnership in Tanzania called Wazazi Nipandeni, where we have convinced them to extend the time period of which they're providing the service from being just around pregnancy to also the first 5 years of a child's life, developing content, integrating this content related both to uptake of deworming as well as nutrition interventions. In other places, we're working on integrating nutrition and health messages into, for instance, agricultural mobile services. Farmers are paying good money for these services anyway. They want information primarily on costs and markets, etc. But they're also very interested in getting more information about various crops, and again, by linking it to the value chain, we can provide them with more information on more nutritious crops. And what we're doing is we're sneaking in messages also that relates to their family situation, and we actually can get a lot of information about their families or the individuals who are accessing such services. And again, lots of other opportunities, lots of financial services through a mobile phone, and there'll be more and more in terms of health insurance, et cetera, et cetera. So, in summary, I think it's, without having gone into the details, I think there's lots of evidence for why we need to work together those of you who are primarily interested in NTDs versus those of us who are primarily interested in nutrition. Secondly, I think that we do have fairly good evidence, although we're constantly, of course, exploring and understanding better in terms of what to deliver, but that the area in terms of how we deliver those services is one that could definitely use a lot more innovative thinking, innovative approaches to help us ensure that these services are also being taken up by those individuals who need them. And with no further ado, thank you very much.